for hosting us today, and for all of the personnel that were here to give us tours and explain equipment to us. We really appreciate it. As you know, I'm from Minnesota, and I was the one that was really cold. So thank you for closing the door. I think they put me here on the end thinking, oh, the Minnesotan can handle it, but not so much. So I appreciate that. But and I also want to thank, Congresswoman Van Dyne and Dr. Burgess and Congressman Arrington for having us here, and I will tell you, all of them hold a very special place in my heart, and so for various reasons. I serve with all of them on various committees, and I just want to tell you that the Texans are very well represented by them, and so they are treasures. So keep sending them to DC because we love working with them. But just so you know, I represent a very rural district. Most of the members have mentioned those things, and the same kinds of things that Congresswoman Tenney had mentioned about, not being able to get healthcare providers. And I was so glad when telemedicine was finally mentioned, because it's something we're focusing on. And just so you understand, if you look at Minnesota, I'm the western half from Canada. I border Canada, and I'm one county short of Iowa. So I've got all of that. My largest city is 50,000. So when we're talking rural, it's a serious issue. And so, emergency response is huge. I mean, and even just getting basic care, my folks have to travel quite a ways just to get the basic care. And so telemedicine is so important. And, and my hospitals survive as critical access hospitals. That's how they survive, because they're very concerned about the 340B and the beds. And so from what I've talked to them about, that's why they haven't switched over. But I am very interested in the community paramedic program, and I know that Mrs. Miller mentioned it, and I believe Mr. Smucker mentioned it, because I believe in Minnesota at one point we did have some pilot programs that the state was covering, because I was in the state legislature before I came to Congress, and so I'm just kind of talking about, I know that improves potential outcomes, and I'd love for you to talk a little bit more about that, because in one of your statements you said sometimes they just need a hug. And I think those folks are the repeat kind of that will call 911 and be, so I'm not even going to try. Matt, would you address that for me?
Sure, and congratulations. Minnesota was one of the first states to authorize and pay for community paramedicine services through Medicaid because of the rural areas in Minnesota. And in many of those communities, the only providers that were able to go see those patients were the specially trained local EMS agencies who had the foresight to, Dr. Wilcox and others who were big drivers in that program, to be able to deliver essentially basic primary care for patients in the rural areas to prevent them from having to call 911, to keep them healthy, educate them about their healthcare programs. So, but the same model or the same principle applies from a rural area to a very urban area like ours. We have 20, 30, 40 patients at a time in our high utilizer group patients, our HUG program, and they run the gamut from behavioral health issues to uncontrolled diabetics to uncontrolled asthmatics, pediatric patients. We just did a program, or starting a program with our children's hospital because they're part of the CHIP program. And they said, even though the state won't reimburse us, meaning the CHIP program, because it's not a covered service, the CHIP program is willing to pay for it because it reduces their cost, and they actually will make out better financially by having fewer patients go to their own hospital and having to pay their hospital for those ER visits. So when we look at those patients, the fixes, if you will, and it's typically a 90-day enrollment. We don't want to adopt those patients. We don't want to make them codependent on us. We want to teach them how to better manage their health care, so that, like the patient that would have come here to testify, instead of calling 911 20 times in 30 days, we get her connected to the resources, a new primary care physician who happens to be on the bus line because she doesn't have transportation. So by the community paramedic recognizing that, asking the payer, Medicare, to change the patient's primary care physician to one who's on the bus line so she can actually go see the doctor where she couldn't before, those things are what leads to her not calling 911 in the last 6 months. but it's the EMS agency that can recognize that, because the crew says, well, gosh, this is the 7th time in a month that we've come to your house for a low acuity medical complaint. Let's get you into this program to try and get you to stop calling, but we don't get reimbursed for any of that.
But I also see, and I think we saw so much during COVID with the telemedicine, and one of the things is we talk about broadband, we're looking at making sure that we have that, and like in a rural area available. And I see that community paramedic could be such a partner with telemedicine. And I am out of time, and I appreciate the chairman's indulgence, but thank you all for being here, because it's been a wonderful conversation. So thank you, Mr. Chair. I yield back.